We are live. All right,
Right.
Charlie. Perfect. So, I think a good way to start, and I think what's going to be interesting about this conversation, Charlie, is that we're going to be talking about things that many people consider, science fiction. That, when we're talking about, back in the 1960s, we're talking about electronic medical records in the 1960s,
Right.
complete with digital clinical support tools, complete with, digitized knowledge databases. To top that, in the 1960s, we're talking touchscreen terminals where patients can work collaboratively with multidisciplinary teams to enter data, including things like light pens to
Right.
select data on screens. So we're going to be talking about team-based care, total quality management, or continuous quality management, whatever you'd like to call it, CQI, back in the 1960s. I don't think many people are aware of all this work that was being done, well over 55 years ago. We're talking again, EMRs, digital clinical support tools, things that people I think would think is science fiction if I told them this was actually happening well over half a century ago. So I think where we can start is we're going to roll the clock back, and we're going to go back 55 years ago to the summer of 1967. It's almost like a song. And we're going to go back to that summer of 1967 where you were working, and this is what I read, you were working on designing programmed keyboards or key mats to enter data into the EMR. And we're talking 1967.
Right.
And working in collaboration with a team, working on the Human Interface Program, or HIP, that entailed working with what we talked about, the touchscreen DigiScribe terminal, and then even a Zentek light pen for selecting data on screens, part of, I guess, that what became the Promise Laboratory. So maybe let's just start with, summer of 1967. What were you doing? And give us a bit of a description of that work.
Yeah. Well, I was at Cleveland Metropolitan Hospital, where Larry Weed had gone as the director of the outpatient clinic with the whole task of putting in a problem-oriented medical record in a fairly good-sized medical institution. And I went there with him as an intern in internal medicine. And I can't really remember exactly the origin of how I made this decision, but he had a residency open to him in the outpatient clinic, and I decided to take that. So I dropped out of clinical work and started working with Larry. And then he had this idea, well, we've got this information organized in a reasonable way. Computers are coming on. Why don't we see what we can do about trying to computerize the problem-oriented record? And the only computer available to us was the hospital IBM 360 hospital information system. And so our first experiment was developing these programmed keyboards, mats that I could put over a standard keyboard that would allow me to key information about chronic disease. So we worked on that for a while, and soon came to the conclusion that wasn't going to work, and that we had to move on. Larry had made an attempt at that time to get a grant from the NIH to start work on a truly electronic medical record. I then left and went to Duke for another year of clinical residency. By the time I came back, Larry had gotten this big NIH grant. Had hired a few people. Jan Schultz was the computer director. And by the time I came back, they'd gotten this big contract, had a big DEC computer, and the touch cathode ray screens were just coming in to being at that point in time. And so they were already hard at work when I came back, working on building a structured electronic health record.
Right.
And using the touch screens to be able to have either physician or patient themselves enter pieces of their electronic history or pieces of their medical history into the electronic database.
Right. And this was in the context initially at the Cleveland Metropolitan Hospital, and
Correct.
then the team shifted to more fertile grounds, so to speak, at the University of Vermont Medical Center. So I understand that that's a very large health center where they had more fertile ground in terms of a more amenable administration for digitization and leveraging medical databases. Maybe you could speak more about that Promise team and what their vision was, because that was quite revolutionary. Nothing like that existed, as far as I know, in the world in this scale. If you could describe maybe a bit of the context of what they were trying to achieve at the University of Vermont Medical Center in terms of the digitization, everything from the data entry to the data collection to the the data standards to the digital clinical support tools that they're trying to apply within that large setting within a team-based care model.
Yeah, it was interesting. So after that last year of residency, my chief year of residency, and actually that was 6 months of clinical work, supervising the residents, and then another 6 months working with Larry. I had to go into the Army at that point in time. So this was 1969. Larry went to the University of Vermont. I spent 2 years at the Army Surgeon General's office working on developing computerized algorithms for common medical problems that could be used by corpsmen in an outpatient clinic at Fort Belvoir, because this was the time of the Vietnam War. They were just being overrun with not only military people, but their families and dependents. And so Larry set up his record on an OBGYN ward. And I was not really involved in that. I really just, heard about it. And I made the decision then to not follow him to Vermont, but to come up here to Maine and join this practice that was really based on Larry's work. It was really the first clinical practice in the country to put the problem-oriented system in place.
Right, and that was with Harold Cross and John Bjorn, I believe, right, in Hampton, Maine. That was back in 1971.
That is correct.
And that, as you said, that is probably one of the most, to say the least, one of the most revolutionary clinics in the country that was applying, Larry Weed's vision and philosophies and operational tools in the practice. And we'll maybe have even another video where we can talk a lot more in depth about Larry, because probably whoever's hearing us right now will have to look up Lawrence Weed and who we call Larry Weed, and the creator of the problem-oriented medical record, but also then is a pioneer in the development of electronic medical records and also clinical decision support tools known as problem knowledge couplers and medical databases. So, but that's for maybe even another talk, because I think this is going to lead into a series of talks. But could you speak more about that transition in 1971 to the clinic with Harold and John, in terms of the description of the clinic that you're working in and the type of digital infrastructure that you had in place and how that worked in relation to patient care?
Yeah. Now, Harold had been an intern with Larry up here at then, which was Eastern Maine General Hospital, where Larry had come to put the idea of a problem-oriented system in place, knowing that it would not work at a large medical center. And then Harold went into practice after 1 year of internship and set up this clinic. He and Larry spent some, really quite a long period of time trying to think about how would this be organized to make a difference. So it really, it was strictly problem-oriented, and they had a defined initial database that every patient who came in went through, and Harold could see right away that collection of a lot of this information could be done, one, either by the patient or by more skilled, trained support staff.
Right. And not the physician.
Exactly, and not a physician. So this whole idea of setting up a structured system with defined rules about what people could do, and then training people to their highest skill level to be able to help with the operation of the whole clinic.
Right. So it's almost like, there are multiple components to the clinic, and that it's very, there are a lot of, it's based on, standards that enables you to individualize care for patients. And, they entail mainly looking at, data entry, like you said, whereby, the team works in collaboration with the patient or their caregiver or family member to enter data in a structured way. So their medical history is there and it's saved, and you don't keep asking the same questions over and over every time they come in. So it empowers the patient to be able to input their data themselves to a degree if they're able to, but then with the support of any allied or support staff if required. So you don't need the physician for that thing. So that's number one. There's the data entry component, which is very collaborative and empowering to the patient. And it creates a really strong dynamic between the team and the patient. The second bit is, of course, the care process, the diagnostic and the treatment process that is based on standards and is based on, digital support tools. So maybe if we can run me through the scenario. Say I'm a patient, I walk into your clinic back in 1971 in Hampton, Maine, and, my first time coming in, what would happen?
Well, we would start the collection of this complete database, which would involve the patient filling out a very extensive questionnaire. This was, in the early days of when chemistry profiles were first coming in. Everybody wanted to collect every piece of information possible. So we really had this huge initial database that everybody went through, including MMPIs and, multiple chemistry tests. And obviously, as more data became available, that got whittled down more and more over time, but it was defined. And so it wasn't left up to the whim of the provider as to what information was going to be collected.
Right.
It got collected. And a lot of that was then initially put together with the first medical assistants. They weren't called that at that point in time.
Yeah.
And we really looked to hire character and teach the skills and find people who had a sense of quality.
Right.
Harold might say, and interviewing somebody, bring me something that you thought you really did well.
Right.
I want to see that. So that was standardized, and then roles started to be better defined.
Right.
And so that initial collection of information, I always thought was sort of our secret weapon.
Right.
Because so much fell out of that about a patient.
Right. And it encompasses like all different dimensions, like physical, psychological, social, environmental,
right.
the totality from a biopsychosocial perspective, right?
Exactly. Very much so. And that whole approach was really just starting to come into being. I think it actually started at the University of Rochester. And so then there was the process of sitting down and defining a problems list with the patient.
Right.
And defining plans for those problems. And very shortly after I got there, of course, this was before electronics at that. We were still dealing with a paper record. Larry said, well, why aren't you giving copies of the record to the patient?
Right.
And so we actually devised a scheme. So we wrote up their history and physical with all their problems and plans for each problem. And we mailed that to them with some trepidation, I can say, in the beginning. But we soon found that was really an effective audit.
Right.
Because we could certainly get comments back that said, I never really said that.
Right.
Or
Right.
that's not what I meant, or that's not how you should interpret that.
Right.
And so drawing them into the process. And then we devised a way, even in our progress notes, that we had these paper shingles that had carbon attached to them, and each one had this SOAP format.
Right.
So Harold used to type his out. I would write mine out. And so a copy of that would be pasted into a page in the chart,
Right.
and the other copy went to the patient.
Right. And you know, that's really critical, the SOAP format, which of course Larry is known for pioneering, SOAP being, you know, subjective, objective, you know, and so that really encompasses the patient perspective in terms of what the problem is, right? So we always kind of jump into the diagnosis, but we kind of miss the presenting problem, you know, and it's kind of like our diagnostic codes don't help with that. The ICD codes go straight to diagnoses, and we use that for billing and everything else. But you know, it's interesting how you really were mindful to engage with the patient from the get-go in terms of, you know, working collaboratively with the patient, leveraging the team. So not the physician, but, you know, allied staff or support staff,
Right.
like I said, in this case, the medical assistant, to work with the patient to make sure that a comprehensive database is available for each individual patient. So that, you know, every time you go to the physician or the nurse or whoever it may be, they know exactly what it is, you know, in terms of the medical history, and they can update it routinely over time.
Yeah, and then we developed, and this was really Harold's work. I mean, I think Harold was probably the smartest guy, other than Harold, that I worked with, or other than Larry, that I worked with.
Right.
And so he devised, for complex problems like diabetes or heart failure, hypertension, we had flow sheets that we used.
Right.
That simplified the data collection process and
Right.
made multiple variables, interconnected variables, visually available to us in the form of these flow sheets.
Right, right. And back in the 70s, when you were working in Hampton, Maine, with Harold Cross and John Bjorn, were you using the problem knowledge couplers that Larry developed? Were you trying to use that, or was that back then in 1984 when you developed your own practice that you started to apply them?
Yeah, it did. Larry's work on that did start in the late 1970s.
Right.
I mean, after he had been running this ward electronically for about 10 years.
Wow.
I mean, his hope was, with the problem-oriented record and medical information organized in this way, that we would make better decisions. But he kept finding that indeed we still were failing. But he said that's just the problem with the human mind, that we're trying to deal with too much complexity in our minds.
Right.
So that's where he came up with the idea of problem knowledge couplers.
Right.
And he first came to our clinic maybe around 1980.
Right.
With this big North Star desktop computer that literally was a desktop. And, and these floppy disks with the idea of the problem knowledge couplers.
Right. So to take a step back, so, you know, folks understand what we're talking about here. So really what problem knowledge couplers are in a synthesis, and you can, of course, describe it better because you had applied work on it, is basically being able to develop a database of knowledge, medical knowledge, you know, based on understanding the interconnections between various variables, really. And then the application of that knowledge database, you know, web of interconnections of knowledge, to the individual patient problems. So it's almost like you have the medical database, you know, I guess the knowledge, the knowledge database that you would compile over time through the, you know, through research. And then the second thing is to apply that knowledge to the specific circumstances or combination of variables that the patient presents. And that's the problem knowledge coupler, or the digital clinical support tool that Larry had developed, right, back in, I guess, the 70s. And so if you could speak more about that in terms of, you know, now we went from data entry. So it's a very systematic way of data entry when the patient presents, in that the medical history is done in a structured way in collaboration with a team member like a medical assistant. So we talked about the data entry, but then, like you said, you develop a problem list. So the patient, I can come and present with 5 different problems, all of which due to multimorbidity, which you were fully aware of back then, clearly, that, if you have diabetes and mental health issues along with hypertension, they all interact in different ways. So obviously, like you said, in primary care, especially in internal medicine, all the generalist specialties, you're dealing with complexity, patient complexity, right? Biopsychosocial complexity. And that's where you need to be able to apply that knowledge to the specific combinations of variables that the patient presents in terms of the types of problems that are presenting, as well as the type of assets that they have as well.
Right.
So if you could speak more about how you applied the problem knowledge coupler system, the digital sport tool, to your practice when a patient presents, that would be very interesting.
Yeah, well, I think I should just to describe the coupler itself a little bit more.
Sure.
Because the structure was really ingenious, and I think it's really important that, first of all, there was a defined database for every problem, so it was standardized. It wasn't left up to our whim.
Right.
If you had a headache, everybody who came in with a headache was going to get the same structured questions, really based on the International Headache Society recommendations. So you were applying the best known standards at the time. And then that information was combined, and it wasn't algorithmic,
Right.
because that was usually, yes or no, and sometimes it's both.
Yeah.
But it's combinatorial. And so then you were presented with a, history, physical examination, laboratory tests. Then you were presented with an array of options. And these were structured in a way to help you think through a problem. For instance, number 1 on the list might be, even though this is a really rare problem, this person has at least one finding that suggests that, and you better think about it.
Right.
Or next, it might be, if this one finding is present, it's all pathognomonic of a particular problem. Right. And then other causes, which are ranked according to the number of findings associated with each one. Also associated with each one were certain comments underneath, right, which would give you context of how to think about it. And then there would be secondary options that would say, well, if you really want to pursue this further, these are the tests that you should do. Yes. And of course, this was all connected to the medical literature, right, and kept up to date, every 6 months.
Yeah. And I think that's something that is extremely revolutionary and still has, to this date, not been applied properly in healthcare. In that, like you said, what you had developed and applied in terms of the decision support system, the problem knowledge coupler system, is, as you mentioned, combinatorial in nature. It is not algorithmic in nature or probabilistic in nature. You are not applying population health metrics directly to an individual. You're not standardizing your care. You're individualizing their care based on standards. Right. It's on its head. Right now, we are standardizing care, and we are inappropriately, to a large degree, applying population health statistics to individuals, which does not work because, like you said, different combinations of variables can point in very different directions. And that's generally, the operationalization of general systems theory or general systemology. And that's well known, that every individual with different combinations of variables have different outcomes based on their context. So when you apply a population health-based metric, right, and you apply it or impose it on an individual, that does not reflect their contextual reality. And therefore, you end up with iatrogenic care. You end up with lots of problems, with inadvertent consequences of inappropriately applying a statistic that's based on population levels on an individual, and the context doesn't match. So what you had done back in the 70s is quite revolutionary, and it still has not been really applied to a large scale to this date. In that you applied a combinatorial approach to decision support, in that you looked at the individual patient, you looked at their problem lists, you looked at the interrelationships between their problems, and then applied that web of knowledge to the circumstances of the patient. So you can have good, options for care management with the patient. So, that's something I don't think is very well understood to this date. And it really goes down to, like you said, Larry was very humble, and in the sense that he understood the limitations of the human mind. He really understood, and he was a big critic of the medical education system to this date, which is based on a Flexnerian model. You go to med school for 4 years, 6 years, 8 years, you memorize a lot of things, and you get a white coat and a stethoscope, and out you go. And then when a patient presents, you're supposed to magically know and understand all the various care options based on the presenting problems that the patient presents. He understood 50, 60 years ago this was not possible, based on the reality of complexity. It's far too much information for the human mind to process. If you could speak more to Larry's philosophy in that sense, in that he was, of course, very critical of the Flexnerian medical system, but he offered solutions to it. And if you can go back to that point of the biases in the human mind, the limitations of the human mind, and how Larry tried to assist and enable humans to think clearly using data.
Yeah, it's interesting because Larry recognized that back in the late 60s and early 70s, where now, particularly after Kahneman's and Tversky's work on unconscious biases and the kind of heuristics we have to develop to overcome that. But Larry understood that way back then. Yeah. And he never gets really a lot of credit for that. And that's unfortunate. So the tool, essentially, I think what you're saying, you standardize the inputs, and that you have variable outputs that are individualized to that unique patient situation.
Right.
But it was the CUPers never said, well, this is the answer.
Right.
It simply said, it engaged the physician and the patient, because the patient's sitting there looking at the same information that the provider is. It's an interesting, because it neutralizes things. We're both looking at the same screen, the same information. They're not looking at me as a provider, trying to read my cues and what I'm thinking. And you might be willing to glance over something, but the patient may say, well, what's that?
Right.
I don't want to have that. Why don't we make sure that we rule that out first? Right. So again, totally engaging the patient into the, one other thing I'd like to go back to, because I think it's an interesting piece of story. Another idea Larry came to us with at the Promise Clinic in Hamden. We had a very bright high school student working for us. She was the daughter of our nurse, and she was doing coding or something like that. Larry said, "Why don't you have her audit your charts?" And so we said, fine. So we sent her over to Burlington, Sarah Taylor, and Sarah spent 2 or 3 days with Larry. He just gave her some very simple rules about how to look at it, how to look at a chart. And then we set her loose on our charts. And of course, it was really pretty interesting and discouraging. We thought we were really pretty good, right, until this high school kid starts looking at our charts. And right, she might look at a chart and a particular problem and say, Charlie, 2 months ago, you said you're going to do this with this problem, and you didn't do it. Why? And so it's just another example of how you apply system and logic, right, to get a better outcome.
Yeah. And I think that goes back to a line that always resonates with me, that the practice of medicine is the medical record. If you go back to Larry's infamous talk,
right,
Grand
sure,
Rounds, 1971, I believe, Grand Rounds in Emory University, I believe it was, and he very, very forcefully said, the practice of medicine is the medical record, and right, the medical record, it structures the thinking. It is the basis of the system of medicine within which practitioners can practice their science and their art. And this really goes to an important point, whereby it really is a useful aid for a physician because like you mentioned, it prompts you to ask questions that you may not have thought of, or you may be biased. So, patient presents with cough, and you may be biased to think in a certain logic whereby you will ask a series of questions. And you ask 10 different physicians when abdominal pain presents, they'll probably ask 10 different types of questions depending on their background and experience and who they see in their population, depending on their affluent area or in a, so really we're biased in the way we ask questions and the way we perceive problems. But what the problem knowledge coupler system did was enabled you to have a structured way to ask questions to patients that is based on the science of what you should be asking. And based on the responses that the patient presents or the test results, it then guides you further into other questions that need to be asked and not be left out, right? So it really helps you be, comprehensive in the care that you provide, in that you're trying to the best of your ability within the limitations of our knowledge, right? Or, medical knowledge, not personal knowledge, but medical knowledge. This is what the questions that you should ask at a minimum. Right. And then the nice thing about the system is that when you do that, you're doing that in collaboration with the patient so that the patient's giving you their perceptions and thoughts. But at the same time, when you both choose on an option, because again, another thing that Larry used to say is that, you are a guidance system. The physician, the nurse, the care provider is to provide guidance to the patient or the family or caregiver on what options to take. We are not to impose things on them. They have a personal choice, they have autonomy, and they are to be making decisions in collaboration with the provider, right? So that's one thing. So when you do choose an option, say, in this case, Charlie, patient presents, you have the medical history, you have the presenting problems, you input the medical record, it's all there. You go through the problem knowledge coupler decision support tool. So you basically are asking all the various questions based on the presenting problems and the combination of variables of the patient. Then you come up to an option. At the very end, you're like, okay, these are 2-3 options that we have to proceed with your care. A medication option, a treatment option, whatever it may be. You choose an option in collaboration with the patient, right? Then you obviously want to do follow-up. Say, come back in a few months. Now you can also see the impact and the outcomes of that decision, and then that goes back into the knowledge database. So the nice thing is that you're building knowledge over time through the care process. So in a way, the medical record is the practice of medicine because your decisions are in there. You can follow it over time and see how well or how not well it worked, quite frankly. But it's also good to the degree where you mentioned about the high school student, where he or she can audit your charts. So now we enter the realm of quality management. In your sense, you applied the Japanese principles of total quality management, TQM, or now call it CQI, continuous quality improvement, right? But you really were leveraging data to see how well you were performing in terms of quality, safety, performance, and that's revolutionary. We're talking back in the 80s. So this is something we still don't do. I remember early in my career in health services research, I met a prominent primary care researcher in Toronto. And I asked them, how do we assess the quality of care in primary care here in Canada? And he looked at me and he said, and I'll never forget it. He said, short of gross negligence, we have no idea what's going on.
Right.
Look at our chart. So if you ask, 10 physicians how well they do, oh, I do great. How do you know? I mean, Larry asked that question in the grand rounds. Yeah, sure. I feel like I do great. But if you don't have a record of what you did and you can't see the outcomes of what you did, how can you say that? So could you speak more about that? Because this is really revolutionary. We talked about standardization of data inputs into a medical record, right? We talked about the standardization of knowledge and the application of knowledge to the individualization of care in the care process, and then follow-up, and then quality improvement. So maybe more about quality of care and how you worked with the team to improve your quality of care based on that audit.
Yeah, well, I think that my education and quality management, fits into that. So we have a really pretty well-defined system. It's standardized. Everybody who comes into the practice is going to be treated the same. You have this, you go through the same process. And so this was, again, shortly after I came up to Bangor and started my own practice in 1984. And one of the reasons I left working with Harold is I wanted to move further into the use of the technology and the problem knowledge couplers. And I don't think Harold wasn't really quite ready to do that, at that time. And so interestingly, another thing that technique and that I got from Harold and John is, and Harold got from Larry, was this whole idea of principles.
Right.
And when Harold decided to go into practice, and Larry said, well, what do you want to do? And they spent a fair amount of time defining what that was going to be and created a document called the Principles of Practice,
Right.
which I continued in my own practice, and it had evolved over time. And it set the standard. I mean, principles, values are fine. I mean, they define our behaviors, but you could take almost any organization's value statement and apply it to a gang of bank robbers. You know, continuous improvement, we support one another, blah, blah, blah.
Right.
Yeah, but principles provide the why.
Right.
You know, thou shalt not kill. You know, it's not going to change over time. So I think that over time the principles evolved, and I'd had a friend and an economist whose wife was my office manager, and Ron Turner. And Ron finally came to me. He said, and he got very involved in TQM and quality management stuff. He worked at a local community college. He said, you know, if I'm going to continue to help you, you've got to learn this stuff and you've got to put it in place.
Right.
So we started to put a standardized management system in place.
Right.
And so that was another big piece, you know, in our development, and became enshrined in my principles of practice as they evolve. So I started actually. So when I came to Bangor, there weren't local area networks at that time. The only computer we had was at the front desk.
Right.
that we used for billing. But I did in the old DOS coupler system, I did have the editor, and so I could work with developing my own set of couplers if I wanted to. But what I focused on was triage at the front desk. So when a patient would call with a particular problem, say sore throat, I started to think, well, what are the questions that we should know right up front? Right. Before we even make an appointment for that patient. Right. Do they even need to come in, or what can they do at home to take care of themselves? Right. So I started working on this triage coupler, which evolved over time to become actually one of the largest couplers in the system, and allowed our and I'll have to send you this, because recently I got in touch with a number of our old patient service representatives, and asked them what working with the triage coupler meant to them.
Right.
And so that it eventually became very sophisticated, covered many different areas, allowed them to determine does a patient have to come in? If not, what can they do to help themselves? If they do need to come in, given the nature of the problem, how much time do they need?
Right.
And who should see the patient? If there is a coupler questionnaire available to help with that, we can email that questionnaire to them before and have them fill it out before they came in.
And what year are we talking about? Date range? When this was
well, this was 1984.
You see, this is why I kind of, you saw me a bit, shaking my head, because we're in the year 2022, and we're the current state, at least here in Canada, and according to the media and according to many people you talk to, the system is in shambles. The system is really in shambles. It's a mess. It's a non-system. It's always been a non-system. And only now in the year 2022, they're talking about this revolutionary approach to how do we triage patients? When they call in, what do we do?